The webinar will begin shortly. Please be ready.
Hi, good evening, everyone, and thank you very much for joining the CEFAM webinar this evening. We're just going to wait a few minutes or a few seconds more, just that we let everyone to get into the webinar. So let us 30 seconds, and then we're going to start the webinar. Okay, maybe let's start. So again, thanks very much for joining CEFAM webinar. So my name is Pierre-Charles, and I am the medical director at CEFAM, and I'm really delighted tonight hosting the webinar with Michael Maikewan, who is managing director of CEFAM United Kingdom. Michael brings a wealth of experience in ventilation and sleep medicine, and their insight into the UK landscape will add a real depth into today's discussion. So we are also very delighted and truly honored to welcome Professor Gagnadoux, who will be addressing a highly relevant and rapidly advancing topic, the emerging cardiovascular risk biomarkers in obstructive sleep apnea. So just to present Professor Gagnadoux, he's a professor of medicine and head of Department of Pulmonology and Allergology at Angers University Hospital. Many of you will be familiar with his recent work published in leading scientific journals, including the American Journal of Respiratory and Critical Care Medicine, the well-known Blue Journal. So where he has focused obviously on cardiovascular risk biomarker in OSA. So we are all aware OSA is a common syndrome affecting up to 10% of the general population and likely more. So it has been considered as a potential cardiovascular risk factor. However, when we look closely at the literature, the relationship between OSA and cardiovascular outcome and all cause of mortality are far from straightforward. So, and similarly, while CPAP remain our cornerstone therapy, large randomized controlled trial, or RCT, have not consistently demonstrated a reduction in cardiovascular event across all patient groups. So this has prompted recently important reflection within the field. So one of the key questions of tonight is whether we have placed too much emphasis on the apnea-hypopnea index, the AHI, as a principal indicator of disease severity. This is a growing recognition that the AHI may oversimplify what is in fact an heterogeneous and complex disorder. And traditional measures such as AHI and oxygen desaturation index do not consistently predict cardiovascular risk. So for this reason, there has been significant effort in recent years to identify more meaningful markers, particularly those that may better reflect cardiovascular vulnerability. So this evening, thanks to Professor Gagnadoux, he will help us to explore this emerging biomarker and consider how they might enable a more personalized therapy, phenotype-driven approach to treatment, especially in relation to cardiovascular risk. But before handing over to Professor Gagnadoux, I would like to invite Michael to provide the UK perspective by addressing two questions. And the first question would be, Michael, what is the current prevalence of obstructive sleep apnea in the United Kingdom?
Well, thank you everybody for coming, and for two distinguished guests, thank you for taking part in this. The UK is a population of around 67 to 69 million. We always try to work that out. And the estimated diagnosed population is about 1.4% of the population, roughly 600,000 to 700,000 individuals. But and that's probably undiagnosed, and there's probably loads more undiagnosed. If you take the Bedgerfield 2019 paper, that you could actually look at something like nearly 10 million of the population who have OSA. So that's a very large population. And then if you also then look at the heart failure, atrial fibrillation numbers as well, there's bound to be a big crossover with those patients. So it's going to be very interesting to hear what the new biomarkers, what they can bring in terms of bringing those two parts together.
Yeah, and then what is the strategy, or what are the strategies that are currently being implemented in the UK to mitigate those cardiovascular risk in those patients, especially?
We try to screen on diagnosis and collect the records of the patients, their previous history, and the management of comorbid conditions. Again, it's they tend to go into the pot. What we do share here in the UK is within our physiology departments is quite often they are connected with the lung function and the cardiac physiology teams working together to screen. And then you look across at other conditions like diabetes and hypertension, both in primary care and in the sleep clinics, that recognise that both conditions coexist in these populations. So what we try to do is look at the lifestyle of the patient predominantly, and then look at all of the risk factors around that, things like alcohol consumption, smoking, physical activity. So, but we are probably just as an outside observer, not always connected together. What we do experience here is we have high waiting lists for basic OSA diagnosis. So there may be other routes that we can go into through the cardiac area where we have this crossover if we are looking at the right biomarkers.
Okay, and so Michael, you may say that there is a lack of robust and clinically validated biomarker that would allow us to better stratify those cardiovascular risks in this specific population. You would agree with that?
I think again, I think individually that the teams know about these factors, but I think the challenge is connecting them together in the right place in the pathways. And certainly where these functions are stressed in our healthcare system, because there's a lot of patients in the systems and the way the system actually operates, I think some clarity is absolutely necessary. And certainly I've been a fan of reading the professor's works on bringing this all together. And I think we're going to see change over the next few years in how we actually bring all of this together. So.
Okay. So, but thanks, Michael, to bringing up your perspective. So with that, we will now turn to Professor Gagnadoux. So Professor Gagnadoux will guide us through this development and in a clinical focused presentation, so including case-based discussion. And during this session, everybody in the room will have the opportunity to take part in a short interactive quizzes. You will have 30 seconds to respond, and you will be able to submit your question as well that we will answer by the end of the webinar. So we will select, not because they might have many questions, so we will select some question at the end of the webinar and to ask to Professor Gagnadoux. So thank you again for everyone for joining this evening webinar. And Professor Gagnadoux, over to you.
Thank you very much. Good evening, everybody. Thank you very much, Pierre-Charles and Mikhail for the very great introduction. Thank you for the CEFAM for organizing this webinar, and thank you to all who are connected this evening. So, as mentioned, Pierre-Charles, I'm going to try to discuss the potential value of these novel biomarkers based on a case report. So we start with this case report. It is Mr. G. He's 70 years old. He's retired and he has a history of shift work. And his main medical history is coronary heart disease, which was revealed by a cardiorespiratory arrest. The patient was stented in 2002 times. It is a non-smoker and he relates no alcohol consumption. And in fact, the patient is referred by the general practitioner for a pulsatile morning headache, and which started started in September 2024. The patient had a comprehensive workup with neurological, ophthalmological assessment, brain MRI. All was normal, and on the interview, the patient had few symptoms of sleep apnea. He says that he wake up in good shape, and he has no daytime sleepiness as assessed by the EPRO score, which is 5 upon 24. This is, so you perform a sleep recording, a polysomnography, and this is the summary of these sleep studies. As you can see, the AHI is very high, 61 per hour, with a supine predominance, and also there is a component of mixed apnea, 30% of mixed apneas. Regarding SpO2 values, the ODI is 43 per hour. The time spent below 90% of oxygen saturation, the T90 is 3%, and we have calculated the sleep apnea specific hypoxic burden, which is at 120% per minute per hour. Regarding sleep values, you see that the sleep onset latency is relatively short, 14 minutes. The patient had a quite long intra-sleep wakefulness, about 1 hour and a half, 62 microarousals per hour, and he had 24 periodic leg movement during the sleep study. So the first question is this one: which of the following points make you hesitate to initiate PAP therapy in these patients? The absence of clinical complaints related to sleep apnea, the positional dependency, the fact that the patient have 30% of mixed apneas, the quality of sleep, and the presence of periodic leg movements. So you have now 30 seconds to vote, and you can start voting. Pierre-Charles, you comment maybe the result?
Yeah.
Yes,
So,
great.
So 53% provided an adequate response with the absence of clinical complaints related to sleep apnea.
Okay, so good job. Indeed, I think the main good answer to this quiz was the first proposal, the absence of clinical complaints related to sleep apnea. So this is an important point. I think today the main reason to treat sleep apnea is to improve symptoms related to obstructive events during sleep, and this is the French criteria for the reimbursement of PAP therapy in France. And you can see it is mandatory to have at least 15 events per hour of an AHI of at least 15 events per hour, but also associated with at least 3 symptoms among this list of 6 symptoms: daytime sleepiness, severe daily snoring, gasping during sleep, daytime fatigue, nocturia, and morning headaches. So, of course, we can go further in the interview of these patients to try to report other symptoms that were not listed, but at this point, the patient only had morning headache as symptoms. One question is whether you can be sure then headache can be related to sleep apnea. This is a very nice review which was published in Sleep Medicine Review in 2024. And as you can see, there were very discrepant results across the different studies, some showing a strong association between OSA and headaches, and some showing no or even a negative association. And at the end, on the summary, there was a trend for a positive association, which was not significant. So if somebody has only complaint, which is headaches, before considering that it is due to sleep apnea, you have to perform a comprehensive evaluation, as it has been done for our patient, to exclude the other cause of headaches. Regarding positional sleep apnea, this is a study that we have performed in our cohort. Remember that the definition of POSA is a supine on non-supine AHI ratio of at least 2. So a twofold more higher AHI in supine compared to non-supine, and we usually call exclusive POSA those patients where they are events only in the non-supine position, in the supine position, with a non-supine AHI below 5. So POSA is not rare. As you can see in our cohort, almost 50% of patients with OSA had a positional trend, but exclusive POSA is more rare. What we found in this study is that POSA compared to non-POSA were less likely to adhere to CPAP and had a lower benefit of the treatment, and particularly for exclusive POSA, but it's not, of course, a contraindication in our patient who had very, very high AHI and very severe sleep apnea. Regarding mixed apnea, as you know, mixed apnea is defined by the first part of the apnea, which is central, with no movement, no effort, and the second part of the event is obstructive. What have been found, for example, in this study is that the highest component of mixed apnea at diagnosis and the highest is the risk of persistent central events under CPAP, what was called at this time COMSATs, and which is called today emergent or persistent central sleep apnea. So the risk of emergent or persistent central sleep apnea is higher in patients with a high proportion of mixed events at diagnosis, but of course it's not a contraindication for the prescription of CPAP in our patient. And finally, regarding the problem of insomnia, as you know, the association of OSA and insomnia is called COMISA. And again, it's not a rare situation. As you can see in this review, 30 to 50% of the patients with OSA have comorbid symptoms of insomnia. It's important to discriminate the different presentation of insomnia, initial, middle, late insomnia. And in this study, what was found is that those with initial insomnia or late insomnia at a lower were less likely to be adherent to CPAP. But on the contrary, middle insomnia was not associated with a lower risk of adherence, which was the case of our patient. Our patient had middle insomnia. So again, in our case, these symptoms was not a contraindication to try CPAP in our patient. But we have to be aware that in patients with very severe insomnia symptoms, you can have this kind of treatment with frequent interruption of PAP during the night and also a higher risk of central events under positive hour pressure in COMISA compared to patients with OSA alone. So we go now to the second quiz, and the question is choose the appropriate response for the T90. The T90 can be expressed in minutes or percentage. This is the time of sleep or recording with SpO2 below 90% of oxygen saturation. It is more strongly associated with cardiovascular risk than the ODI. It takes into account all the desaturations following apneas, and Mr. G had a particularly high T90. So you have now 30 seconds to vote, and I will vote also.
So then 38% provided adequate response with the first answer. It can be expressed in percentage or minute. 76% provided an adequate response as well with this is the time of sleep or recording with an SpO2 below 90%, and 35% responding well as well. It is more associated with cardiovascular risk than ODI, 3%.
Okay, great. So we're going to discuss these different points. So as you mentioned, Pierre-Charles, the good response to this quiz were the first three proposals. It can be expressed in percentage or minutes. It is of course, the time below 90% of SpO2, and it is more strongly associated with cardiovascular risk. So this is an illustration of how the T90 is calculated. This is an oximetry trace of one night, and the T90 is the cumulative time that we see here in blue of time spent below an oxygen saturation of 90%. And 90% of oxygen saturation is a very low saturation. It corresponds to a PO2 of about 60 millimeters of mercury, which is really a low PO2. So it takes into account all this time below 90%. And yes, it can be expressed either in minutes, but it's probably better to express it as a percentage of recording time or sleep time if you have performed a polysomnography. So there was one question regarding the T90 of our patient, which was 3%. This is again our cohort, the Pays de la Loire sleep cohort, almost 9,000 patients who are investigated for suspected sleep apnea. And as you can see, the median value of the T90 is 2% for all the population. And when you look at the most severe case, those patients with more than 30 events per hour, the median value of T90 is 10. So despite severe, we say our patient had a T90 of 3, which was a quite low value. So the proposal was not exact. Mr. G has a relatively low value of T90 despite very severe obstructive sleep apnea in terms of AHI. So this is an important point. The question was whether T90 is more strongly associated with cardiovascular risk than ODI, and obviously it is. This is a very nice study published in the European Heart Journal in a clinical cohort in a epidemiological cohort in the US of elderly male. And as you can see, when you look at the association with survival, there was a strong association of increasing T90 with lower survival, and particularly for the fourth quartile of patients who have a very lower survival compared to those with a milder desaturation. But compared to T90, as you can see, the ODI was not associated with survival, and the association of T90 with survival remains significant after adjustment for confounder. So T90 is undoubtedly, and it has been confirmed in many cohorts, more strongly associated with cardiovascular risk than the ODI. But the problem of T90 is that it is not specific of obstructive sleep apnea related desaturation. There are two components in the T90. One component is a distinct desaturation due to intermittent hypoxia, and it takes into account all the desaturations that goes below 90%. So the proposal that saying that it takes into account all the desaturation is not true, because it takes into account only desaturation, acute desaturation going below 90%, but it takes also into account a patient with sustained hypoxia due to low daytime PO2 that can be related to COPD, obesity, or heart failure. So it has a prognostic value, but it is not specific of sleep apnea desaturation. And you can have some patients such as this one with very high T90 but no OSA. You can see this patient have a T90 of 78%, but when you look at the oximetry trace, there is no pattern of intermittent hypoxia, and you can see that the AHI and the ODI is very low, and obviously CPAP won't do anything on this kind of desaturation that are due to comorbid condition but not related to obstructive sleep apnea. So efforts have been made to develop novel biomarkers, and we have now a quiz regarding the sleep apnea specific hypoxic burden. First proposal, the sleep apnea specific hypoxic burden can be derived from single pulse oximetry. Second proposal, it takes into account the duration and depth of the desaturation. Third, its value being between 0 and 100. There was a mistake, there was an error in Mr. G observation. Fourth, it's better correlated with cardiovascular risk than the AHI. And finally, a high value predicts better cardiovascular response to PAP therapy. So it's time to vote. Okay.
So 27% provided a right response with it can be derived from single pulse oximetry. 67% provided as well a right answer. It takes into account the duration and depth of the desaturation. 57% provided a right answer. It is better correlated with severe risk than HI, and 43% provided as well a right answer with high value predict a better cardiovascular response to CPAP therapy.
Thank you, Pierre-Charles. So indeed, there was 4 good response to this quiz. So this is the way the sleep apnea specific hypoxic burden is calculated. You have here an example of apneas and desaturation consecutive to these apneas. And as it was proposed, the hypoxic burden is the area on the curve of desaturation, and it takes into account both the depth of the desaturation and the duration. This is why it is expressed in percent minute per hour, and you can have very, very high value. There is no upper limit. You have some patient with 200, 300% minute per hour of hypoxic burden. It is a discriminant biomarker. Then this is an example of 2 patients with similar AHI, 25, very similar ODI, 26, 23, very similar T90, 6 and 5%, but huge difference in terms of hypoxic burden. And this guy has a relatively low hypoxic burden, which probably predicts a low cardiovascular risk compared to this one, who have a very high hypoxic burden of 74% minute per hour. So it can, so it can make the difference between 2 patients with very similar traditional metrics of OSA severity. So what have been found, what have been demonstrated both in epidemiological cohort in the US and in clinical cohort, this is our studies in the Pays de la Loire sleep studies, is that the higher is the sleep apnea hypoxic burden, the higher is the sleep apnea hypoxic burden, and the higher is the risk of cardiovascular mortality, or inversely, the lower is the probability of survival. And you can see that there is the same finding in a clinical cohort in our patients investigated for suspected OSA, with an increased mortality, a decreased survival in patients, in patients with high sleep apnea specific hypoxic burden. And we also demonstrated the predictive value of this biomarker with regard to the specific outcome, stroke. Just look at the cutoff value. This is an important point. There are differences between cohort, and in this epidemiological study, patients with a hypoxic burden higher than 50% minute per hour were at increased risk. This is the blue curve. And in our cohort, there was an increased risk of cardiovascular events for a lower value of sleep apnea hypoxic burden, 31. So they are in both cohorts an increased risk associated with high value, but the cutoffs are different from one study to another. There was a question regarding the fact that we can calculate this biomarker from single oximetry, and indeed it has been demonstrated here in this study. I won't detail the methodology, but as you can see, the predictive value of HbOxy, which was automatically calculated from the single pulse oximetry signal, the predictive value with regard to cardiovascular mortality was very similar to that observed with the original metric sleep apnea specific hypoxic burden determined on previously scored polygraphy. So it's very interesting because with only oximetry you can calculate this biomarker. So the next point, which is very important, is whether this biomarker can also help to predict cardiovascular response to the therapy. And as mentioned in the introduction by Pierre-Charles, there were 3 randomized controlled trials, SAVE, Ricardza, and Isaac, which were performed in secondary prevention in patients with overt cardiovascular disease and at least 15 events per hour, and in minimally symptomatic patients. And as you know, these 3 trials were neutral and showed no benefits of CPAP on cardiovascular, secondary cardiovascular prevention. So some authors have performed a post-hoc analysis. This is this study from the Spanish group. In the Spanish study ISAC trial, this is in patients with coronary heart disease and minimally symptomatic. And as you can see, when you take the entire cohort, there is no protection of CPAP on cardiovascular risk. But when you stratify the patient based on the baseline hypoxic burden value, as you can see, there was a protection in those patients with high hypoxic burden, but no protection in the patient with low hypoxic burden. And interestingly, in this study, this was the simplified version HbOxy which was used, which make it very easy to obtain. So this biomarker can help to predict the risk, to stratify the risk, but also probably to stratify the likelihood of the patients to respond to CPAP therapy. And in this study, when the authors tried to stratify the patient with traditional metrics of OSA severity, for example, AHI or T90, as you can see, there was no prediction, there was no effect of this biomarker for the stratification of PAP response. So clearly, the hypoxic burden performed better than the AHI and the T90 to predict the risk and also to predict the cardiovascular benefit of PAP therapy. So we move now to the next quiz, and now we go to other biomarker, which is the cardiovascular autonomic response biomarker, and we have again 5 proposals. The delta heart rate is the average increase in heart rate following apneas. A high delta heart rate is associated with a higher cardiovascular risk. Delta heart rate can be extracted by oximetry alone. A high pulse wave amplitude drop index is associated with an increased cardiovascular risk. Delta heart rate and P-WAD index correlate with OSA severity. So no, you can vote.
Okay, then the majority has responded well again. So 60% have responded adequately. The delta heart rate is the average increase in heart rate following apnea. 80% of the attendees have responded well as well on a high delta heart rate is associated with a higher CV risk. And 34% have responded well on delta heart rate can be extracted by oximetry alone.
Okay, thank you, Pierre-Charles. So indeed, there were 3 good responses to this quiz. So we're going to discuss these different points. First of all,
if I may say just 1 second, I would like to remind the attendee that you still have a chat box like down there, like in the Zoom, when you can ask question that we will select by the end for Frédéric Gagnadoux. So please don't hesitate to ask question in this chat box. We'll be able to provide that at the end of the webinar.
Great, great. Thank you, Pierre-Charles. So, first of all, the delta heart rate have been described like this. You can see two patients with obstructive sleep apnea, one here and one here. And as you know, at the end of the event, there is an increase in heart rate, which is related to the activation of the autonomic nervous system. But when you compare those two patients, you can see that this one has the highest increase in heart rate after the events compared to this one who have a lower response. So the delta heart rate is very easy to calculate. It's the mean increase in heart rate after the events, after all the events that occurred during the night. And what have been found here again in population-based cohort in the US is that those patients with a high delta heart rate at baseline had an increased risk of non-fatal and fatal cardiovascular events, and it remained significant after adjustment for confoundant, and the threshold which was found in this study was 10 BPM, a mean increase of 10 BPM. There was a question regarding the fact that the delta heart rate can be calculated by oximetry alone, which is again very important because we need to be able to calculate this biomarker with simple tests. And we have demonstrated in this study in the European Respiratory Journal in two distinct cohorts, our cohort, Pierre-Charles sleep cohort, and Hypnolos cohort, which is the cohort from Raphael Anzer in Switzerland. In the general population, so it's really distinct population. We have demonstrated that the delta HR heart rate automatically derived from pulse oximetry as a good prediction value. And as you can see in the two cohorts, those with a high delta HR derived from oximetry were at increased risk of cardiovascular events in these two cohorts. But again, there was different threshold according to the population considered. Another important point again is whether this biomarker is able not only to stratify the risk but also to predict the response to treatment. And again, a post-hoc analysis of the Ricazza cohort in patients with coronary heart disease in Sweden. Again, when you take the entire population, no protective effect of CPAP compared to usual treatment. But when you stratify to the baseline value of delta HR with a cutoff of 6 BPM, there was a protective effect of CPAP in those patients with high delta heart rate, but no protective effect in patients with low delta heart rate at baseline. So again, this biomarker is easy to calculate both from polygraphy or pulse oximetry alone, and is predictive not only of cardiovascular risk but also of PAP response in patients with minimally symptomatic subject at high cardiovascular risk. The third biomarker which have been developed is the pulse wave amplitude drop. These have been developed by the team of Raphael Anzer in Switzerland. It's not very complicated to calculate. It's just the number of drop of pulse amplitude, as you can see here, of at least 30% drop of pulse amplitude. Taking into account drops that occur after respiratory events or that can occur without any respiratory events. So interestingly, we have work in three distinct cohorts: the Hypnolos general population, Pierre-Charles sleep cohort, which is patient referred for clinical suspicion of OSA, and also the ISAC cohort, which is a cohort of patients with coronary heart disease, so very high risk of coronary disease. And what is the first finding which is interesting is that the more severe is the population, and the lowest is the PWAD index. And in the three cohort, as you can see, there was an association of PWAD with cardiovascular risk, but you have to keep in mind that it's completely different to delta HR. Those who are heart rate, those who are at higher risk are those with the lowest PWAD value, both in Hypnose, Pays de la Loire sleep cohort, and Isaac trial. So it is a different biomarker, and those patients with low value are at increased risk of cardiovascular disease, whereas for delta HR, it is those patients with high value who are at increased risk. So to conclude, we have three different biomarkers, which is the hypoxic burden, the delta heart rate, and the PWAD, who can be derived from pulse oximetry alone, and also who do not measure the same thing, because as you can see, when you look at this correlation metric, there was a relatively strong correlation between the hypoxic burden and OSA severity. The delta heart rate correlate really with autonomic reactivity, and there was no correlation between these different biomarkers each other. So probably it is interesting to combine them to obtain a better prediction of the risk. And this is what I've been recently done in this study, which was recently published in the European Heart Journal. So this is the Boston team who have published this study, and they took the population of the three randomized controlled trial, RICADZA in Sweden, ISAC in Spanish, and SAVE, which was the largest one. And they pooled all of these cohort, and they stratified the risk of cardiovascular disease based on the combination of high hypoxic burden, and look at the threshold, 47% minute per hour, or high delta heart rate with a threshold of 9 beats per minute. So it is a or combination. You are at high risk if you have high hypoxic burden or high delta heart rate. And what they found in this study, again, when you take the entire population, you confirm that there is no protective effect of CPAP compared to usual care. But when the population is stratified, you can see that there is a reduction in cardiovascular risk in the high-risk group, and no protective effect, and even a deleterious effect of CPAP in the low-risk group. And this is confirmed in subgroup analysis, and particularly in patients without excessive sleepiness, without high blood pressure, or the combination of the two conditions. So it's particularly interesting because it is in the patient with few symptoms or without high blood pressure that the predictive value of this combination of biomarker is predictive. But what is quite surprising in this study is that in the lowest group, and particularly in patients with low compliance, there is a significant deleterious effect of CPAP, which was quite surprising. So I think this finding has to be confirmed and further evaluated. But this study showed that probably if you combine those two biomarkers, and particularly in minimally symptomatic patients, it can help you to decide to treat with CPAP with the objective to reduce the cardiovascular risk. So if we summarize all of this, you have your patient with obstructive sleep apnea. You have traditional metrics to make the diagnosis, and probably the AHI remain a good metric to make the diagnosis of sleep apnea. And then today we have three distinct biomarkers: the sleep apnea specific hypoxic burden, which can be derived from pulse oximetry alone, and the highest value is associated with a higher risk, but also with a better cardiovascular protection to CPAP. You have the delta heart rate, which can also be derived from pulse oximetry alone, and a highest value is associated with a higher risk and a higher treatment response to CPAP, and also the pulse amplitude the pulse wave amplitude drop, and it goes in the other way. The lowest value are associated with an increased risk, and probably it's interesting in the future to combine. And we have today data showing that probably the combination of those two biomarkers, hypoxic burden and delta heart rate, is interesting for a better prediction of PAP response in terms of cardiovascular risk. So if you summarize these biomarkers are potentially interesting for PAP treatment decision, and it's particularly interesting in patients at high cardiovascular risk with few symptoms. And it was the case of our patient, our case report. He had a very severe sleep apnea, but very few symptoms of obstructive sleep apnea. But there are some limitations today, and the major limitation is a lack of standardization of the methods for calculating the biomarker and also for oximetry recording. And the consequence of that is that we do not have today a universal threshold, a universal cutoff to decide to treat or not to treat, and probably the cutoff values differ from one population to another. And this is just an illustration of the difference between two oximeters with different performance. You compare in a very huge population, almost 10,000 patients who have an oximetry recording with two different oximeters, one with a high resolution and one with a low resolution. And as you can see, when you compare those two oximetric recording, the fact that to use high resolution versus low resolution gives really important difference for all the oximetry biomarker, hypoxic burden, but also the ODI and also different other biomarkers of oxygen desaturation. So it is important to keep in mind that if you change the device to record the patient, and if you change the population, the thresholds are not the same. The predictive value are changing from one population to another, and we have to work to standardize the methods to calculate this biomarker. So we will finish with the last question for Mr. G. Finally, you have decided to treat this patient, and you have started positive airway pressure, self-adjusted positive airway pressure, with a range from 4 to 12 centimeters of water. And you see the patient after 7 days of CPAP, and this is the data download from the machine. And as you can see, when you look at the residual AHI without taking into account central hypopnea, you have a relatively low residual AHI, less than 10 events, and few central events. But if you take into account central hypopnea in this patient, you have a very high residual AHI of 27 events per hour, with a huge number of central hypopnea in this patient. So very important when you look at the data download from the device to know if your machine takes into account central apneas in the calculation of residual AHI. So there was one quiz to finish this presentation for this patient. Which of the following responses are correct concerning treatment emergent central sleep apnea, or TEXA? First proposal, the appearance or persistence of central apnea after starting PAP for obstructive apnea. So, sorry, the treatment emergent central sleep apnea is defined by the occurrence or persistence of central apnea after starting PAP for obstructive sleep apnea. Second proposal, common causes of central sleep apnea should be excluded before confirming TEXA, for example, use of opioids, heart failure, atrial fibrillation. Third proposal, reassessment after several weeks of PAP is recommended before confirming the persistence of central events. Fourth flow waveform analysis may help differentiate central from obstructive events. And the last proposal, Cheyne-Stokes respiration is present in all cases of patients with treatment emergent central sleep apnea. So now you have time to vote. Okay.
So 83% provided an adequate response with the appearance or persistence of central apneas after starting PAP for obstructive sleep apnea. 67% provided as well a right response with common cause of CSA should be excluded before confirming TESCA. Reassessment, and 69% provided a right response with reassessment after several weeks of PAP is recommended before confirming persistence. And 44% provided as well a right response with flow waveform analysis may help differentiate central from obstructive events.
Okay, thank you very much, Pierre-Charles. So indeed, there were 4 good responses. Of course, treatment emergent central sleep apnea is the occurrence or persistence of central events in a patient who had an obstructive sleep apnea at diagnosis. Okay, for this. The common cause of central sleep apnea should be excluded is really important, and particularly when central apnea occurs after several months or years of treatment. Before considering its treatment emergent central sleep apnea, you have to exclude something new in the medical history of the patient, for example, use of opioids or intermittent atrial fibrillation or heart failure. This is very, very important. Reassessment after several weeks of PAP is recommended. Yes, it's very important. Some studies have shown that, for example, you have about 15% of treatment emergent central sleep apnea during the titration night, so during the first night of exposure to positive airway pressure. But if you take time, if you take 1 or 2 months at the lowest fixed pressure delivered to the patient, in most cases, central events will spontaneously disappear. And when the machine says to you, you have central events, it's very important to look at flow waveform because it can help you to discriminate between true central events and, for example, Cheyne-Stokes respiration and something who are finally obstructive events. And the last proposal was not true. Cheyne-Stokes respiration, of course, is not always present in patients with treatment emergent central sleep apnea. It has a very important predictive value, and we are actually doing a study showing that if you have Cheyne-Stokes respiration under CPAP, you are at high risk of cardiac complication in the future. But some patients have central events without typical Cheyne-Stokes respiration under CPAP. And the last slides just to remember that there is a very, very strong association with central event and particularly Cheyne-Stokes respiration with cardiac disease, arrhythmia, heart failure, coronary heart disease, and hypertension. It's completely different to obstructive events, and the association is clearly more strong with central sleep apnea. And I thank you for your attention, and of course we are open to try to answer your question if you have some. Thank you very much.
Thanks very much, Frédéric, for this very enlightening presentation. I think everybody agrees around the table. So we're going to just select a few questions. Mike, if you want to start with the first question.
So the first question I have here is to patients with severe SAS with high delta heart rate. Was there any change of this parameter after using CPAP treatment?
In a patient with a high sleep apnea hypoxic burden?
Yes, with high delta heart rate delta, was there any change of this parameter after using CPAP?
Oh, yes, this is an interesting question. I didn't mention this study, but there was one paper from the Boston group also published in hypertension. And what they looked at the impact of CPAP on blood pressure. So they performed a post-hoc analysis of an old study which had been published in the New England Journal of Medicine, and they look at the impact of CPAP or oxygen on blood pressure. And again, they perform a post-hoc analysis, and what they found is that those patients with the more important decrease in hypoxic burden under treatment were those with the best blood pressure response. So this is a very good question. Probably in the future, we will have to calculate the hypoxic burden at baseline, but also to check that the hypoxic burden is markedly decreased under treatment, and probably those patients will have the best benefit in terms of cardiovascular complication. To my knowledge, there is no published study looking at the evolution of delta heart rate before and after PAP therapy. I think there is no published study, but probably it's interesting to look at this also.
That was a question from Christos, right, Mike?
Yes. Yes.
Yeah.
So really, this is an important point. And, we often perform pulse oximetry under a positive hour pressure to check if the patient is adequately treated. And probably in the future, if we can calculate the hypoxic burden just based on the oximetry trace, it will be very, very interesting to see if you have not only a high hypoxic burden at baseline, but if you have successfully decreased the hypoxic burden under treatment.
So I have a question on my side from Suzanne, and a very practical question. When will we say there is a high hypoxic burden? So what are the number? What are the threshold, the cutoff here?
Yes. This is a very very crucial issue, and today we are really unable to say this cutoff is the universal cutoff which is considered high or low, and you should treat above this threshold but not below this threshold, because I think as I mentioned in the presentation, first of all, we have technical issue, and the biomarker can differ between one oximeter and one other type of sleep recording. And the second point, which is probably more important, is that probably the threshold will change from one population to another. And for example, when we look at PWAD index in the 3 different cohorts, there was a similar trend. The lowest value were associated with an increased risk, but the cutoff were very different in coronary heart syndrome patients from the ISAC trial and in the general population. So I think tomorrow we will have also to develop population-specific cutoff, and it is, in the European in the cardiological recommendation, there are already some cutoff, for example, for cholesterol that are different for a woman or a man, or for a patient with or without hypertension. So tomorrow, it's impossible to have one universal value, but probably we have to develop population-specific cutoff value.
Michael?
Okay,
Yes.
there's quite a few. I'm just running about time. Maxime Elbaz, what is the good hypoxic burden to calculate with hope sleep apnea testing or with PSG?
As I showed, it was initially described based on polysomnography. So it means that you have to do a previously scored the sleep recording, and then you run the algorithm who calculated the sleep apnea specific hypoxic burden based on previously scored sleep recording. But as I showed, there is a simplified version based on pulse oximetry alone, and I believe that in the future the most interesting way to use this biomarker will be automatically derived biomarker from pulse oximetry without previous calculation, without previous scoring, because as you know, there is very discrepant difference between one scorer to another in the calculation of hypopnea and AHI. So if you add this inter-observer variability, you're going to lose some predictive value of the biomarker. So I think in the future, the good way will be automatic calculation from pulse oximetry alone. And what is interesting is that the 3 biomarkers that I mentioned can be calculated from only the PPG signal. So if you have a standardized method to record, to take the PPG signal and using also the raw data, not smooth data, probably we can achieve something which is quite standardized and automatically calculated.
Thank you, Frédéric. There are like so many good questions. It's very difficult to select, but we're going to still continue for a few more questions, and then we're going to stop, I think, at one point But I have as well a good question. So pulse oximeter is something that we discussed, Frédéric, already in the past. Pulse oximeter lose accuracy at low SpO2 value, and different oximeter read differently. How this is taken into account when reviewing SAS HB data, also impact of different skin pigmentation. So I just have like the name as Martin. So says great presentation and very informative, by the way.
Thank you very much. I don't know if we have already data comparing, taking into account skin pigmentation, which is of course a very, very important question. And probably the advantage of this biomarker is that, again, it takes into account the different component, both the depth of the desaturation and the duration. So it's different, for example, from the ODI. The ODI is the same value between 2 patients who have very small desaturation, only 3% desaturation, and another one who have very profound desaturation. And what is really obvious is the more severe, the more profound are the desaturation, and the higher is the risk. It's evident. And this is why the T90, for example, have a value. But if you have a patient with very, very low saturation during the night, probably it is not due only to sleep apnea, but also to comorbid condition. And so probably in this case, the sleep apnea specific hypoxic burden lose its value in very, very comorbid patient with very low baseline oxygen saturation. But it is really more specific to desaturation consecutive to obstructive events. So this is its main advantage.
So maybe we can try out like 2 questions more, and we're going to stop here. Michael, do you want to have another one?
Yes. Abuka Denjifil, I apologize for poor. So the question is, in which clinical context might each of these biomarkers outperform the other in predictive value?
I think this is the main advantage of this biomarker is probably tomorrow to help treatment decision in patients for whom you have, for example, this is the case of our case report, very high AHI, but the patients say, I have no problem with sleep apnea. My sleep is good. I wake up in good health, and there is no problem with my sleep. In these patients, you're really, it's very difficult to decide to start a treatment which is a heavy treatment with which add constraint for life. So in these patients for who the objective of the treatment is particularly to prevent cardiovascular complication, it is in this situation that probably the biomarkers are useful, not in the patient with severe sleepiness, because in any way we'll try to treat this patient. So I think the main interest is for treatment decision in minimally symptomatic patients with, for example, diabetes, severe hypertension, previous history of cardiovascular disease. You want to know if treatment will help the patients in terms of cardiovascular outcome.
Thank you, Frédéric. So maybe last one. So one question from Abhishek, again, like, sorry for the spell of the name. If this patient has mixed CSA, he is at higher risk of CSA. Shouldn't fixed PAP be given instead of auto PAP?
Yes, this is a good proposal. I think, as I mentioned, those patients with a mixed component, a high mixed component at diagnosis, are clearly at higher risk of residual central events. So you can start with an automatic titration of the effective pressure, but it's probably better to switch to fixed pressure, to the lowest fixed pressure, to avoid central events. It's a good proposal, I think. Yes. Yes.
Okay, thank you. Thank you, Frédéric. I think we might finish the webinar now because there are like also many few questions. So sorry for the one we haven't been able to reply to those questions, but we also really appreciate that we were so numerous around the table today to listen to Frédéric Gagnadoux, and we really appreciate that. And also would like to thank Michael and all the team who has been able to come up and to set up this webinar. Hopefully we will be able to continue our webinar, so we will have a next one. So please, all of you, stay connected. We will stay connected. We will be able to come up with some new, interesting, and hot topic to discuss with the CEFAM webinar. So I wish you all a good evening, and hopefully to see you soon.
Thank you very much to all of you, and thank you for the great question and the great answer to the quiz. Thank you very much.
Thanks very much.
Thank you. Thank you.
Bye-bye.
Bye-bye.
CEFAM sincerely thanks you for your participation and for joining us today. We invite you to follow us on LinkedIn to stay informed about our latest news and upcoming events. The replay of this webinar will be available on our YouTube channel in the coming days. For any additional information, please visit our website, www.cefam-international.com. Thank you again, and see you very soon.